Hi, I'm Dr. Allison Cole, sleep medicine specialist and bona fide chronic insomniac. Welcome to the Sleep is My Waking Passion podcast. Remember, knowledge is empowerment, and if applied correctly, it can help you biohack your way to a better night of sleep, just like I did. Hello, everyone, and welcome to another episode of the Sleep is My Waking Passion podcast. You know me, I am your host, and today I have a really cool guest. I have Dr. Daniel Barone. He's got many titles, but he is a neurologist and sleep specialist from Weill Cornell. He's also an author. He's published 2 books now. His most recent one came out in March of 2020. It's called The Story of Sleep from A to Z. I love it. It's very cute. And then he also has a book that came out back in 2018, also about sleep. It's called Let's Talk About Sleep, A Guide to Understanding and Improving Your Slumber. So I am just tickled because I have an author, and he's also published a number of papers. So he's really, really active in the publishing community. And he also happens to be Associate Medical Director of the Weill Cornell Center for Sleep Medicine and Associate Professor of Clinical Neurology at Weill Cornell Medical College, and an attending neurologist also through Weill Cornell, New York Presby. So I have a real brainiac with me, and it's just so cool that you were the first real academic dude that had reached out and was like, hey, let's chat. And I was like, I'm fangirling right now. Oh my God. I saw him at Sleep 2023. I know I've seen you before. Your face is very familiar from even, past live stuff, going way back. And then also it's just one of those things where Bankum actually came up to me, Bankum Shaw, and he was like, hey, right when I was sort of departing my previous organization, he came on board. And we have shared so many patients because he inherited a lot of my patients. And then he's like, hey, you should talk to Dan, and you should talk to Al. And so he's like the mega networker that has opened this door to me. And I have to say, I'm curious to see what you think. I thought that NYU conference was absolutely terrific. That's one of the best sleep conferences I've been to in a really long time.
I was honored to be a part of it. I thought it went off without a hitch. And Dr. Al Rodriguez, he really is top of the game when it comes to that.
So cool. So we're going to talk about a super cool topic.
Say how thankful I am to be here, and also the applaud I have for you for taking a step and doing something this cool. So good for you. Good on you.
Oh, well, of course we could pause the podcast to give myself accolades. Why not? Right. It's really nice to have someone who I respect so highly. And also, it's just wonderful to be in this space. And I got to tell you, this is something that is kind of the funnest thing I do in a week. I wear a lot of different hats now that are sort of different. And this is by far the coolest opportunity I have. So I appreciate that you appreciate that. And let's keep doing it, because as we know, there are a lot of sleep problems for a lot of people, and we we don't discuss. And so I was fascinated by your particular area of expertise, which, you've really sort of explored the arena of acting out your dreams. So that's going to be the topic of this talk, is really talking about what we call dream enactment behavior. And when I started off doing this outline, we are taping right before Christmas. And I'm not going to lie, I totally was hanging out, watching The Grinch with my kids when I probably should have been researching a little bit more for this podcast like I usually do. So I told Dan he's an expert, so he's just going to school me on all sorts of stuff, which I'm excited to learn about. But one of your papers that came out recently was really delving into what exactly dream enactment behavior is. And there's sort of these conditions that sort of sometimes seem the same, but they're really different and may actually have long-term implications, such as REM behavior disorder versus some of these other disorders. So I'm going to turn it over to you to kind of tell us, what exactly you mean by acting out your dreams, and what are the sorts of things that we think about as clinicians when we're having a patient describe this to us.
So when we talk about dream enactment behavior, that almost sounds like, well, what is the problem there? I'm acting out my dreams, I'm following my dreams, that kind of thing, which has a more positive connotation, which in reality, what we're talking about, REM behavior disorder, is not. So what tends to happen is every 90 minutes or so, in a quote normal situation, the brain goes into what's called our REM sleep, right? Which is where we tend to dream. Typically what happens during REM sleep, our body is paralyzed. Okay, and nature has designed this for us so that way we don't act out our dreams. So I always think of things in terms of evolutionary perspective, right? So if you think of very primitive human being, If they were to act out their dreams and scream and thrash in their sleep, guess what would happen? They would get eaten alive by
The
some.
saber-toothed tiger or the bear or somebody coming after you. Yeah.
So what happens is normally during REM sleep is our body is paralyzed. And if you've ever kind of woken up out of a dream and been unable to move, you know that is what's happened. It can be a kind of a scary thing. We call it sleep paralysis. But normally, though, this happens all throughout the night, and we just sleep through it, and we wake up in the morning, and that's that. People who have dream enactment behavior, though, that system where they become paralyzed becomes inactive. Okay, so now if the brain cortex is telling them you're fighting somebody off in a dream, what they're going to do is they're going to swing their arms. They're going to scream out. They're going to kick. They're going to maybe even fall out of bed or break their hand on a wall or fall and break their hip. I've seen all these things. What can happen with dream enactment behavior is, sure, it can be dangerous to the person himself. It can also be dangerous to a bed partner. But the real reason we care about this is when we talk about dream enactment behavior as it comes from REM behavior disorder, okay, which is kind of the umbrella term for all this. It can be associated with called synucleopathies down the road. And those are things like Parkinson's disease. Okay, so REM behavior disorder is a really unique condition in that it really affects a person's night-to-night basis on, how they're, sleeping and if they're disturbing a bed partner. But it's also the very, very beginnings, we think, potentially, as far as an open door to looking at longer-term neurodegenerative diseases. So people are really working very hard right now to try to understand this condition and see if there's some way we can maybe see, all right, if you have REM behavior disorder, let's give you a protective agent and maybe stave off some of these horrible conditions down the road.
So, and is it still the case that when we talked about it, you're right, it's multiple types of neurodegenerative disorders.
Right.
Parkinson's is very well known to folks. So they kind of relate to that, but it can be other things. It can
That's
be,
right.
I think Lewy body dementia may be one of the things that are
Correct.
associated with it. So when you hear folks that may, we have some famous folks, unfortunately, have some serious neurologic conditions, that kind of fits into it. And is it still the case that sometimes the REM behavior disorder can be what we call a harbinger or happen years and years and years in advance? Yeah. I heard somewhere around 25 years. Is that still sort of true today from what we know?
Great point. So the nice thing about this condition is that, or, quote, nice thing about it is that it usually precedes these type of neurodegenerative illnesses by 10 plus years or so. So it gives people, it gives researchers time to try to, figure this out, but it also gives the patient time to kind of say, all right, look, I got to get my stuff in order, which I've had many patients come to me and they just want to have that knowledge. Unfortunately, there's not really much we can do about it, but at least they know this could be a possibility. Now, I just want to say, not everybody who has dream enactment behavior has true REM behavior disorder like we're talking about. Okay, and we'll get into the more nuanced things. But if somebody is diagnosed with true REM behavior disorder or idiopathic RBD, we're not sure where it comes from. There is a high risk after about 10 to 12 years of at least having the beginnings of these terrible conditions.
I have to say, in clinical practice, when I've counseled people,
right,
that's one of the things that we always worry about, because I don't want them leaving the office being like, oh my God, my life is about to fall apart. But at the same time, there are some realities to that. I guess my question would be, I've been pleasantly surprised in a way that people have not exhibited super freak out behaviors. I'm hoping that it's the way I'm telling this to them.
Sure.
And also, unfortunately, there's not a whole lot you can really do about it. Now, are they still enlisting some people into databases? I know I've heard of folks where I'm like, if they have that condition, I'll say there are some people that are studying this, and what they'll do is they'll basically follow you over time so that we understand. But to date, we don't have any magic to prevent any of these synucleopathies from actually, kind of evolving.
That's right. And you bring up a lot of great points there. One of those is in how you tell the patient, right? If you say, look, you're going to develop this guaranteed, then of course anybody's going to leave there and be upset. But a lot of times when patients come to me, they kind of have already an indication that this may be what's going on. They'll look it up online and they'll know the kind of the facts. But what I'll tell them is what I'll tell you here. And this is somebody who, I'm coming at this from somebody who does research in this field. I don't think that everybody who has RBD goes to see a doctor. And in fact, I think most people who don't go see a doctor have this condition. Why? Because, well, if you don't have a bed partner, how would you know you're acting out your dreams? Unless you've fallen out of bed or really had some extensive circumstance, even then you probably wouldn't necessarily go see a doctor. So I think that the numbers that we read in literature are actually very, very skewed. Okay. And I tell patients this for hopeful reasons, which I think there are way more people who have RBD that don't develop, synucleopathy or one of the neurodegenerative diseases that just never go see a doctor, so it never gets diagnosed. Okay, I think that's an important point. I don't know exactly how much percentage of the people that we talk to have, are in that category, but it is something to know.
So what about some conditions, and you alluded to it,
Mhm.
as did I, that there are other conditions that sort of,
Right,
I don't know if it would be fair to call them mimickers. That might be the best way I'm kind of constructing in my brain, where it's not true, as you mentioned, idiopathic, or we don't know why it occurs, but it's not a true harbinger of true, like pure RBD in that sense, or REM
right.
behavior disorder, but it's sort of associated with other things. Can you talk a little bit about some of those conditions?
Absolutely. Yeah, I'm glad you brought that up. So one of those, which we talked about prior to the recording, was pseudo RBD. Okay, and what that is, that's people who, if you just watch them, without having any kind of monitoring, they will scream out, they will flail their arms, they will kick during sleep. And what's actually the cause of that is not, impending doom, but in actuality, it's just sleep apnea, severe sleep apnea, where the person is stopping breathing throughout the night and their brain kind of puts them into almost like a fight or flight type situation. And they end up, people will say, I have dreams where I'm underwater and I'm trying to fight to get up and not drown. So you do see that more so in severe cases of obstructive sleep apnea. A sleep test would kind of help you to delineate that. If you look in the literature, there's actually some comparisons between pseudo RBD and RBD. And without having any monitoring, it looks exactly the same. The same
Wow.
it's the same kind of actual acting out, the same kind of screaming. So it's really, just because you act out your dreams doesn't necessarily mean that you have this condition. That's one. Number two is RBD associated with an antidepressant, right? So if somebody gets placed on usually an SSRI, so that's like things like Zoloft, for example, and there's others like tricyclics, that also can develop RBD. Now, there's some data to suggest that actually is true RBD that's being unmasked. There's also some that suggest that it's just a side effect of the medications.
Wow. So a thought for you, because I'm curious about this. A lot of the SSRIs
Mhm.
actually might reduce the amount of REM that you
That's
have,
right.
right? They're like REM suppressants. So
That's
to
right.
me, it's a bit ironic. Like I'm trying to
Right.
wrap my brain around the fact that you might actually see RBD of all things with the SSRIs.
Right. And it's ridiculous because if you look in the literature of case reports of things that have been tried for RBD and have had success, paroxetine is one of those medications, which actually it says in the column, it's like may treat RBD, but also it's like may cause RBD.
And
Yeah.
definitely, I wanted to make one other comment, which is
Yeah.
that you are spot on when it comes to the sleep apnea. And one of the things, guys, to know, and Dan alluded to it, when we're in this rapid eye movement, this REM sleep, our bodies are paralyzed. And that means our upper airway, the muscles that affect our upper airway, are essentially paralyzed because they're voluntary muscles. I mean, we're still breathing, we're doing some autonomic functions, if you will, but your airway is going to be actually one of the things that we always talk about as sleep nerds is basically a lot of times if you're going to see sleep apnea, meaning the true, what is most common, which is obstructive sleep apnea, we typically, you hope that person gets REM because usually if it's going to be at any stage, it's going to be in REM.
Right.
So one of the things we used to postulate, if you will, in sleep fellowship when we talked about it would be, well, if your sleep apnea also tends to be much worse in REM, that would be like the perfect storm of now you're dreaming,
Right.
now your airway's closing off a ton. Your dreams get super weird because your body's like, hey, wait a minute, you really need to wake up. Okay, I'm going to give you some scary dream that's going to cause you to wake up, and then you're acting out or screaming or any, bunch of things that can happen during that time. Anything to add to that, or would you agree with that? Because I've definitely seen that in real life.
Yeah, 100%. I mean, usually what you'll find is patients who have, severe sleep apnea, let's say, for example, they may tell you they don't dream at all, right? And you put them on CPAP, and all of a sudden now they are dreaming because they're able to stay in that REM sleep. So, just another reason to take care of it. One other condition, though, I do want to bring up here, which is very, very important, is narcolepsy. So narcolepsy, we're talking to clinicians here, right? For the most part.
We are talking to the general populace, but what I promise you is narcolepsy's been a topic. Guys, if you really wanted to take a deep dive, I have definitely talked to Kevin Tries. There's going to be some more episodes coming up. I interviewed Julie Flygar. You're going to get a lot of information about narcolepsy. So just so you're aware, we have skimmed it. We have tried to provide some education along that, but thank you for bringing that up.
So narcolepsy, as you guys will find out, it's really a condition where people are excessively sleepy, but there are other symptoms as well. People can have hallucinations, people can have this thing called cataplexy. But one of the things that people don't really ever discuss about it is REM behavior disorder can actually occur quite often in narcolepsy type 1, especially in children. It actually
I had no idea.
It may be the initial symptom, honestly, in children. So if a child is acting out their dreams, you're not thinking neurodegeneration. You're thinking, could this be narcolepsy? So something to consider.
Wow, I didn't think about that. That's not okay. We've definitely never touched that. So that's groundbreaking to me. This is the first I've heard of that. Interesting. Yeah, I've never had a patient mention that to me, but I'm going to keep that in the back of my mind. Okay. Yeah. I mean, I've seen adults, but
yeah. If you think about narcolepsy type 1, right, where there's a lack of orexin, which is orexin is a stabilizing molecule. It kind of keeps us asleep when we're asleep, keeps us awake when we're awake. If you no longer produce that, what can happen is REM sleep, especially, and wakefulness kind of intrude onto one another. And that's where you get like this kind of mishmash of stuff. REM behavior disorder being one of them.
It would be cool if that was part of the criteria, so it brings it to the forefront when people hear of it. That is really interesting. And now a quick break, but don't go anywhere. We'll be right back.
Struggling with sleep? Dr. Cole is here to help. Whether you need a comprehensive sleeping coach program, suspect you have sleep apnea, or simply seek a second opinion, she's available for consultations in New Jersey, New York, California, and Georgia, with more states coming soon. Schedule your free 15-minute consultation today to find out which visit is right for you at AskTheSleepMD.com and start your journey to better sleep with a trusted physician.
If you are liking this podcast, if you're finding it educational, if you are feeling more empowered to go to your doctor with any sleep issues that you might be having to address them, please, please, please lend your support. Make sure that you are liking, following, subscribing. I am available on YouTube. I'm also on Apple, Spotify, wherever you get your favorite podcasts. The website has launched. So we have AskTheSleepMD.com to be your free educational resource. We've added many new blog posts filled with juicy information. If you would like to support the podcast, we now have a way for you to donate. This is a labor of love. I truly enjoy what I am doing. It would be inspiring and truly helpful if you wouldn't mind even so much as donating $1 to keep this podcast going, particularly if you really find this free education a good platform for you and a good resource for you. I also have affiliate links for products that I'm a proponent of, such as Quiet Mind. So please check out the website. Sign up and you will get the latest news, the latest blogs, some sleep tips, and just have a great day and keep listening. Okay, guys, sleep well. And you also, we've talked a lot about very practical pseudo RBD type of things, but you also did a great article touching base about post-traumatic stress. And then you also mentioned some traumatic brain injury mixed in with that. And then you also talk about trauma-associated sleep disorder. And these two can have some associated dream enactment type of behaviors. Can you explain to folks what those conditions are?
Yeah, I'm glad you brought that up. So trauma-associated sleep disorder is kind of a newer described condition, and really only started seeing it in about 2014. So it's only been about, discussed in the last 10 years or so. But basically what it is, it's kind of like a mixture between PTSD and RBD. So let's say somebody goes through a traumatic event, whether it be, war, or they have, a home invasion, or something happens. What tends to occur, as we know, is PTSD, right? So they may have nightmares, they may be hypervigilant, they may be, on edge all the time, right? On top of the other symptoms. But they also may act out their dreams, meaning that they may scream out, they may get up abruptly, those kind of things, in the context of a nightmare. Trauma-associated sleep disorder is all of that, plus they have, on a polysomnogram, an overnight sleep test, they have elevated muscle tone during REM sleep. So it looks like RBD. If you know anything about the patient, you would see, oh, look, this person muscles are active during REM when they shouldn't be, but they also have this history of trauma. So it's kind of like a mixture between the two of PTSD and RBD.
So PTSD, PTSD and TASD, or trauma-associated sleep disorder, would both of them, you'd see that sort of you'd see more activity during REM?
Not so much with PTSD. PTSD, you may have clinically, they may say, I scream out or so, but a sleep test, a polysomnogram, is not going to show that muscle activation that we see in RBD, whereas TASD will.
Oh, wow. Oh, this is really cool for me too, because we talk about PTSD, and it strikes me as oftentimes people may share their story with me, so that there's some trauma, but sometimes if they're not, this is one of the things that we try to do, and this is why it's important when you're even kind of doing Dr. Google research, guys, just be mindful that, you want to come to whichever, if you're really concerned about sleep disorder, see one of us. Don't even hesitate, make that appointment. And come with that history, because the more information you give us, the better we're able to serve you.
Right.
So if we know these things like, hey, I have these nightmares, and sometimes they're very recurrent or kind of about the situation too, that can be really, really helpful.
That's right. And it's a loaded term. Dream enactment behavior is a very loaded term. What does that mean? Does it mean that they're sleepwalking? Does it mean that they're, just talking in their sleep? I mean, these are benign conditions. Or is it truly this REM behavior disorder or trauma-associated sleep disorder, which are a little bit more, on the sinister side?
And when Dan is mentioning things like sleepwalking or somnambulism, dream enactment, we're very specifically talking about something that's occurring during a stage of sleep where our brains are really active, but our bodies are paralyzed. So we're not supposed to be moving. But those other, once you get into the weeds of somnamblism and other types, we call those parasomnias, but really they're occurring in a different stage of sleep, usually a deeper stage of sleep.
Right.
And that's one of the reasons I think that kids tend to have a lot more of the sleepwalking and some of the other things, because they just have more deep sleep than we do.
They do.
They're growing. They need all that growth hormone to get big. And we're old and crusty, and we don't need it anymore. So I guess we get it removed from our repertoire as we age.
That's right.
Say. Let's talk about treatments. And then also just treatments in terms of non-pharmacologic treatments.
Yeah. So, the new practice parameters came out not too long ago, and the mainstays of treatment for REM behavior disorder really have much, which is either melatonin by itself, Klonopin by itself, clonazepam, or a combination of the two. Okay, so usually what we do is we'll start off with, at least how I do it, is I start off with high-dose melatonin. So we're talking maybe 5, maybe 10 milligrams. Usually the highest I'll go is maybe 12 to 15. Okay. And the person will take that right around bedtime. And, if it helps a significant amount, great. We just keep it on there and keep it going. If not, if it doesn't do enough, then what I may do is either switch them over or add to it low dose Klonopin. Okay. So high dose melatonin and low dose Klonopin. And that usually I start off with 0.25, same idea around bedtime. Of course, assuming that sleep apnea and other conditions are taken care of. Either alone or together, those two do pretty good work, as far as reducing the symptoms. So what you tend to hear is the bed partner will say, well, he's much more quiet now, or he or she is much more quiet now during sleep. They're not screaming out as much. I see a little bit of twitching or a little bit of moaning, but it's not like it was. That's a success story. Okay. Outside of those things, it becomes much more nebulous, because there's case reports of this medication or that medication. Things like Xyrem has been used, which is a medication for narcolepsy in case reports. But really, you're getting into the realm of all right, let's try it out. There's not really great data to support it. Okay.
Can you
Sure.
explain a little bit of how melatonin and the Klonopin, like, how do they work? Why do they seem to be effective? Because we do know at least a little bit about those.
Right. Melatonin, we have no idea. We have no idea how it works. We just know it does. Klonopin, we think, works on a couple different ways. Is that, it's a REM suppressant, so it may, reduce the amount of REM the person gets, but it also is a muscle relaxant, so it may also, addition to its, anxiolytic properties, it relaxes the musculature. It may reduce the likelihood that muscles are going to be activated. So we think that that's how it works.
Oh, wow. Okay. I feel like I remember from my brain is so old and crusty right now. This is like over a decade old information. But I feel like when I was in sleep fellowship, we would discuss that melatonin somehow, like we thought of it like Klonopin reduces the behaviors, like you said. It's kind of relaxing the muscles. But the
Right.
melatonin somehow, the thought was that it intrinsically affects that connection between muscle activation and not. And truth be told, it was a discussion that we had in fellowship. I can't say that I know the exact paper that information came from or anything, but
That's really interesting. I've never heard that, but I
maybe
love
that was just one of my attendings isms
Right.
or something. I don't know.
Right.
But wow. Okay. So
Yeah.
sorry to interrupt. I'm going to let
No,
you
sure.
continue, please.
Right. So out of those two, after that, it's really is kind of a crapshoot. Now there are other things that people can do though, like you had mentioned, non-pharmacologic treatments, such as, this goes without saying, you want to make sure the bed environment is safe. So what I'll do is I'll have patients of mine cover their dresser, right, so they can't hurt themselves that way. I may have them even pad the walls so they can't break their hand. I've seen that before. One of the big things I will do is if somebody has a tendency to fall out of bed, is I'll have them take like couch cushions or so and put that around the bed, obviously being careful when they get up out of bed to go to the bathroom to not trip. But the nice thing about having a couch cushion is if they fall, there's likelihood that they're going to hurt themselves. One of my patients, she bought on her own a very low bed. So that way, if she does fall out, she's not going to hurt herself that way. I've had patients do bed rails. And believe it or not, sometimes insurance will cover that.
Okay.
Yeah. In a very severe case, I've had one patient sleep in a sleeping bag because we just could not get the dream enactment behavior under control.
Oh, that is a really clever idea. And I was also thinking if anybody has kids, I'm thinking like they make these like blow up bumpers now. I've got bumpers coming out of my butt, the kids are bigger now, but I mean, then you have the old school rails, like you could just recycle some old stuff that's around too, if you need to try to do that. And the little corners, I look at it like, it's almost like you're baby proofing again. Like you get the corners for the edge so that they don't bump their, I love all those suggestions. Those are great.
Right.
What do you tell people about alcohol? Because I had a very interesting case years ago where person clearly was describing REM behavior disorder. And the trick though was that he was a real wine lover. And by wine lover, I mean like, he liked his wine and not just a couple glasses. For me, I was just like, I can try to give you some melatonin, but I'm pretty sure when I researched it that alcohol tends to worsen things, right? But Klonopin also works on the same receptor. So he was sort of like, well, why, why can't I drink if Klonopin works, that kind of thing. And I was like, it's not a bad question to ask. So I was curious as to what we know about it and whether or not it had anything to do with the half-life or what have you. I'm not sure.
Right. Well, again, though, it goes back to there's so much about this condition that we still don't know, right? So we think we know why Klonopin works, but we're not 100% sure. Alcohol definitely makes things worse. Okay, so whether it be it causes micro disruptions in the sleep and that somehow brings us on, that could be, it's hard to say. But for sure, though, alcohol and the way you think of it is one drink usually takes us about 2 hours or so to metabolize it out. So if you go to bed with a few drinks in you, there's a very good chance that and REM behavior disorder is something that you have, good chance it's going to get worse. Plus, you don't want to use that in combination with Klonopin or other things.
Yeah, not a good plan for you. Alcohol in general, if you're really heavily consuming it, there's other than like toxicities and stuff that, you can listen to the Huberman Lab. I've referred to his episode because it's like 3 hours long. It's really dense, but it's
Right.
chock full of really useful information. But the bottom line is that alcohol does affect your sleep quality, right? You
That's right.
tend to have like the deeper sleep in the beginning, but then you'll
Right.
have like a REM rebound. So I almost wonder too, if it's like all of a sudden you've been suppressing your REM and then you're metabolizing the alcohol through the end of
Right.
the night. And then all of a sudden you're having all this REM. And then it's just
Right.
like chock full of time when you can have
Right.
behaviors. And then
Right.
alcohol will make your sleep apnea worse too, because it
That's right.
is a muscle relaxant, just like Klonopin helps to relax your
Yep.
muscles.
That's right. Yep.
So there's a lot of things there. What's the latest research or what can we expect down the pike? What are people
Yeah.
looking at related to this condition?
I think right now, we're still trying to figure out, who really is at risk. Like I've published some research in this as well, looking at who of this subset of people who have this condition, that we diagnose them as RBD, who really is at risk, and are there a way to stratify that, right? Is there a way to stratify that and say, okay, look, person X, you have this, this, and this, you are definitely going to get Parkinson's. Person Y, this, you don't have this, this, and this, you're probably going to be okay. That stuff is still trying to be worked out. However, the holy grail right now is neuroprotective agents. And I think what'll happen probably in the next 10 years or so, my guess, is we will really start to have trials, like real legitimate trials of substances, whether it be medications, whether it be stuff like that, to say to an RBD person, look, we diagnosed you with this, take this, we're going to monitor you over time, and hopefully this prevents or staves off neurodegenerative illness. That's the next move.
I have one final question for you.
Sure.
Melatonin, you mentioned that sometimes you use a bigger dose.
Right.
And guys, there's times when we're going to recommend different doses. Like if you're just trying to reset your schedule, we'll tell you take
Right.
a teeny tiny dose. If we're trying
Right.
to, change your circadian rhythm, it's
Right.
generally not great as a sleep aid for insomnia based on the literature, but that doesn't mean that some people derive benefit for whatever reason.
That's right.
But in terms of, there's so much like what brand do you get? So do you I always I tell them, look for a USP label. Are there any key quote unquote brands or labels that you recommend that people explore, gummies versus tablets, for example? What are your recommendations for that?
It's so variable, and like you pointed out, the literature actually there was a recent paper about this. The difference in branding or the difference in potency from one brand to a next is like a factor of 100. So
It's
ridiculous.
ridiculous.
You don't even know what you're getting, honestly. So I would say it's important to try a trusted brand, So a natural is one I use myself, and I also recommend it for my patients. What I would tell somebody is whether it be RBD or not, if you're trying to use melatonin as an aid to get you to sleep, immediate release usually is fine. Start off with like maybe 1, 2, 3 milligrams, somewhere in there. If you're trying to stay asleep, and again, assuming that sleep apnea has been ruled out, you want to maybe do a time release version, again, up to maybe 5 milligrams or so. If you're talking about REM behavior disorder, that's a different condition, different situation. Probably start off with that same brand, but different dosage.
So guys, what you will hear, because in speaking with Dan, you're hearing different milligrams recommended.
Right.
And when I've talked to Pedram in the past, Pedram Nawab, I did an episode with him, he'll say, oh, no more than 2 milligrams. The bottom line is what you're not hearing is, hey, take 10, 20 milligrams. Like if you're really struggling with your sleep that bad, and you're trying to just melatonin it away and it's not working, there's probably something else going on, and you should seek one of us to talk to. We are here. This is what we do.
100%.
Dan, this has been such a fun conversation. I am so tickled that you wanted to share your expertise with me. Go out and get his books. He is an author. This is amazing. And you can go see him at Weill Cornell if you're in New York as well. Thank you so much. This is so cool. This is amazing.
Thank you so much for having me. And again, congrats on this podcast. It's awesome. Glad you're doing it. Keep up the great job, okay?
Thank you. Disclaimer. The statements made on this podcast have not been evaluated by the U.S. Food or Drug Administration. They are not intended to diagnose, treat, cure, or prevent disease. The information provided by this podcast should not be used as individual medical advice. While I am a practicing sleep provider, I am not your sleep provider. You should always consult with your personal healthcare provider for individual recommendations and treatment.